Greeting to all our friends, and thank you for the opportunity to be with you virtually. Today, I'd like to share with you my thoughts about Ethiopathogenesis of Endometrioma and focus on some basic technical management. I thank the organizers for the kind invitation and allowing me to be with you, and hope we will meet in person soon. Endometrioma is not really well understood. I do work with all these companies, certainly not related to this talk, but I do work with them on product development and teaching. I do like to thank my fellows and the residents, also my assistant, for helping me to prepare this presentation. Most of the material I would refer to are from the book that we have published with the drawings and the detail that it is available free online. I will touch the basic on Ethiopathogenesis of endometrioma, focus on evaluation, imaging, operative technique, and also post-operative management. Endometrioma is a general topic similar to endometriosis, but we do have variation on superficial, deep infiltrative, with adhesions, without adhesion, etc. But unfortunately, as of today, there is no consensus about how to approach it. This is the latest guidelines that I would recommend freezing and look at it in detail, or you can pull it up, that expectant management has some benefits and some risk, so there's surgical management. But if I focus on the potential risk of surgical management, I'd like to emphasize that it is very operator dependent regarding the preserving the ovarian function or trauma to the ovary, etc. Usually, adnexal masses are diagnosed in patients on evaluation for pain, infertility, or on screening for prevention of ovarian cancer. Interestingly, indications for surgery are the same. If a patient has pain, infertility, or we would like to prevent ovarian cancer. I encourage all of you to ask your patients to download this app, which is free online, on patients that they are suspected for endometriosis, and they can answer certain questions, and it would give them an indication, statistics of how their chances are on having endometriosis. As I mentioned, endometrioma is how we look at it. It's the art of diagnosis and management of endometrioma is important. If we look at this picture, depends on what angle we are looking at. It could be a full profile or a half profile. How does this apply to endometriosis and ovarian cyst and endometrioma? This is a patient with pain that she had an ultrasound. The radiology says it appears to be a functional cyst. Follow-up ultrasound in 6 weeks is recommended. But this patient has pain. We look at it, we raise the ovary, and as we get closer on assessment, you could see the pelvic side wall exactly over the ureter and proximity of the uterosacral ligament. These are fibrotic endometriotic lesion. We look deep down further behind the ovary, and you can see the fibrotic tissue is affecting the hilum of the ovary. So not only this could cause pain, it could compromise the vascularity to the ovary also. Further, we aspirate the cyst, And on the cortex and on the surface, you see those hemorrhagic spots. And then we get deeper into the ovary itself, and she does have a corpus luteum and also a type 1 fibrotic endometrioma. So similar to the picture that I showed you, looking around and looking deeper, it would help us assess better in diagnosis and management of the endometrioma. In 1992, we published an article classified endometriomas in type 1 and type 2, and type 2 itself subclassified in A, B, and C. As of today, the literature, the reports we see on endometrioma, it is not detailed on classification and looking at the variation on the type of endometriomas that we are dealing with. And I encourage all of our colleagues to look into it deeper, and hopefully we see more literature coming out. Theoretically, the deep endometrioma is when a functional cyst forms a surface adhesion and endometrial cells grows inside the cyst. It creates deep fibrosis, chocolate material, because it's trapped in. It forms surface adhesion and leads to endometrioma, mainly type 2. And if you look at the type 1, it's more of a surface penetrating deep. They are a smaller cyst, very fibrotic. They are harder to remove, and it's usually comes in a piecemeals. When we look further, the type 2 endometrioma are the typical functional cyst that as the time goes on, you can see type 2A, the majority of the cyst wall is free, only a small surface is invaded by the endometrial implants. Very similar to functional cyst, unless we put the focus on the one area of endometriosis and fibrotics. And these are the ones that pathologists, if they are not familiar, they could report them as a functional cyst. These are easier to remove. Then type 2B has further area of the invasion and surface fibrosis going deeper and more difficult to remove, except the cyst wall, and the size usually is also bigger. When we talk about type 2C, is the worst type. It has caused larger area of invasion. It has severe adhesion and fibrosis to the side wall. And if we are not careful, it could compromise the actual ovarian cortex and ovarian function. So what is our strategy when we're managing the ovarian cyst? Although the statistics are low and the chances of ovarian cancer in reproductive age and endometrioma cancer is less than 4 in 1,000, and that's a paper we published in early 90s, we treat it as it could be cancer. Peritoneal cytology, inspection of the entire abdomen and pelvis, contralateral ovary. Usually these cysts ruptured, and if they do rupture, we do copious irrigation and peritoneal lavage and inspect inside the cyst for vegetation or any excrescences. As far as the technique is concerned, the idea is to mobilize the ovary without tension. The manipulation is very important. We do follow exclusively microsurgical principle published in late 60s, 70s by Victor Gomel. and that avoid tissue devascularization. I will show you how I use hydrodissection, and for hemostasis, I do not use any energy sources. Occasionally, we may need to use hemostatic agents like Fluocil, but usually is not required. Excuse me. And as if it becomes necessary for suturing, we do a reapproximation without tension. I do my perioperative ultrasound evaluation myself, color Doppler evaluation, and it helps me identify where the vascularity of the ovarian cortex is and find the thinnest part, as you can see on this, the thinnest part of the cyst, and away from the blood supply to the ovary. So this is the case. As I mentioned, we do a thorough evaluation and then treatment. So this is a 23-year-old with pain. You can see we do choromotubation, right tube is free, left tube is adhered to the left uterosacral ligament. She has endometriosis in the ovarian fossa down to the left pararectal and rectovaginal area. You can see all these lesions. She has cortical endometriosis on the right side, very similar to type 1 endometrioma. But the ovary on the left side has a type 2C. This is a hydrodissection of diluted pitressin. So the least amount of energy is a CO2 laser, and we could use even scissors to make this incision. The rest of it, as I mentioned, there is a large part of the cyst which frees and shells out easily, but then the fibrotic part, which is more severely adhered, and that's the part that either could be cut with scissors or I use CO2 laser. These are the cortical endometriosis, which is vaporized. The adhesion of the tube and the ovary is freed, and you can see cyst is inoculated and removed easily. The residual adhesions of the tubes are freed. This is the 40 PDS monofilament intracortical suturing with reapproximation of the edges. As I mentioned, it's just simply to bring the edges together and avoid any strangulation or tissue necrosis. Then we will pay attention to the contralateral ovary cortical endometriosis is treated, and also the disease in the posterior cul-de-sac. So how do we distinguish between endometrioma and the functional cyst? As I mentioned, when you do have a chocolate cyst, it is more of a macroscopic diagnosis on the area of the most fibrotic. So sometimes it would help that even with suture, the area that clinically I suspect endometriosis, for the pathologists to look at that area. And these are the different clues that it would help us identify the endometriotic cyst versus functional cyst. This is a case similar to the other one, but this is a robotic approach. This is a 5mm robotic ports that I used. And as you see, this is a type 2C endometrioma on the right side. The ovary is adhered to the right pelvic side wall. Simply with hydrodissection and blunt dissection, we separate the ovary. Extreme care is taken to avoid ovarian tissue adhere to the side wall, otherwise it would cause ovarian remnant and more problem. So the cyst is aspirated, irrigated, we remove all the chocolate material. Now, this is a hydrodissection, as you notice here. Just simply by injecting diluted pitressin in normal saline, the majority of the cyst wall is inoculated and it's removed without any trauma to the ovary. It's only the ovarian edges and the cyst edge, the fibrotic area that I mentioned, which was adhered, and now here just by traction, counter traction using millimeter by millimeter technique, we remove the cyst without compromising or damaging the ovarian tissue. As you notice here, I even avoid grabbing the ovarian cortex. Simply all the tension and grabbing is on the cyst until we approach one area who would require gentle traction. And with the robot, because there is no tactile feedback, we avoid extreme pressures. The frequency of the post-surgical ovarian failure, it depends on which literature we look at. And as I mentioned, how we manipulate and manage the ovarian cyst. This was an article by Busacca, who is a great surgeon from Italy, and in 126 patients, still had 3 cases of ovarian failure. What about the cyst wall ablation versus cystectomy? Ablation or aspiration alone increases the risk of recurrence. Excision there is less risk of recurrence. However, as I mentioned, requires extreme care and skill. There are data using laser or plasma jet aspirating the base of the ovarian cysts. I recommend having a small biopsy first to make sure we are not dealing with cancer, although it's rare, and that may be an alternative to consider. As far as infertility is concerned, I refer you to this paper that we published in Fertility Sterility. And even in patients with IVF and failed IVF, when we took care of their endometriosis, the chances of a spontaneous pregnancy and also more successful IVF was significantly better. So to summarize, definitely there are concerns that surgical treatment may result to decrease the function of the ovary. There are now some data coming up that suggest egg retrieval, egg freezing before approaching the ovarian cystectomy. So this is a work in progress, and that's the whole idea of, for me, emphasizing that we need to change our glasses and the way that we are looking at endometrioma, look deeper on the type of endometrioma, and definitely have a more focus on more micro-surgical principle approaching this pathology. I'd like to thank my assistants that helped during the surgery. And also I would like to thank you for allowing me to be with you today. I encourage you to reach the Worldwide Endomarch website. There are presentations that you may find it helpful. And I would be more than delighted to share with you any presentation or this one, if you wish so, and to write to me. Have a great rest of the meeting. So long. Bye-bye.